In for that. Now, I want us to talk about cancer. In 2021, the world crossed a sobering new threshold. An estimated 20 million people were diagnosed with cancer and 10 million died. According to WHO, these numbers will continue to rise in the decades ahead. In Africa, around 1.1 million new cases of cancer are recorded every year, resulting in up to 700,000 deaths. Breast cancer, along with cervical, prostate, liver, and colorectal cancers, account for almost half the new cases on the continent annually. Now, as the world marks World Cancer Day, we want to take stock of the situation. And joining me to have this conversation is Dr. Omar Sherman, who is the Chief Pathologist at Life Care Hospitals. Thank you very much for joining us and welcome.
Thank you.
All right, so those statistics are really scary if you look at them from the surface. But before we even get to them, talk to us about where we are when it comes to cancer, not only in Kenya, but in Africa in general.
Okay, thank you, Ashley, for hosting me today. I think Kenya, in particular, in Africa in general, the diagnosis of cancer is improving steadily. Some of these figures, we need to look at them objectively. There is the element of the incidence of cancer increasing, but there is also an important aspect that are we diagnosing cancer more than we used to in the past? And I think the answer is yes. If you look at the national cancer policy for Kenya, 2019 to 2030, it's a very comprehensive document, and it clearly acknowledges the need to improve diagnostics as far as cancer is concerned. If you look at the statistics for Kenya in particular, as of today, there are 97 licensed active pathologists in Kenya. And we have a population of approximately 53 million. That makes one pathologist for every 554,000 Kenyans. Now, 97 might seem a fair number, but I can tell you probably 35 or 40 are around Nairobi and the environs. And the environs. What does this mean? This means that there are some areas in Kenya where there would probably be one pathologist for 1 million people. And that number is not good. I will give you a number from the United States. There are 5.7 pathologists for every 100,000 population. So you can imagine we are almost 30 times less, or they are 30 times more than us if you look at the accessibility or the pathologist to the public ratio. And also in those areas whereby there are no pathologists, the rate, the delays in diagnosis is bigger because then for areas, for regions or for counties that don't have a practicing pathologist, they would have to refer to the regional center. Now that regional center not only serves its own particular county, but it serves several other counties that are surrounding it, and therefore the workload on those particular pathologists is very high, and thus the delay. So
what does that mean for universal health care? Because, you know, we've been saying we're trying to achieve universal health care for everyone, but if we look at the ratios, the numbers that you've given us, they don't seem to be where they need to be. What does that mean for our country?
I think what it means is, as much as these policies are very good, and I laud the Ministry of Health for trying what it can with the capacity that it has, I think they need to be more focused in training doctors. This country is not short of doctors. This country is not short of young talent that wants to go out and serve the public. it's to make resources available to these particular doctors. There may be some element of incentivization that, say, for example, the devolution governments say they can take up this and say, what is our problem in our particular area?
Yeah.
We don't have an oncologist. We don't have a pathologist. We have doctors that we have employed within our county government. Why don't we pick one or two and we can send them with the intent that, look, we are binding you. We are sending you to do this, master, so that you come here and you serve your people. So there is no element of risk in the sense that you've actually bound that particular person. Say, look, we are sponsoring you to go and study and then come back for this particular task. I think that way we are going to make strides. Another thing is also foreign partnerships. I'm sure there are countries out there who would be willing to support as far as development of this particular sector, whether it is a matter of training pathologists or it is a matter of training oncologists. Or oncology nurses. I don't want to put this as a matter of doctors only. It's not. It's everywhere. Oncology nurses, chemotherapy nurses, radiotherapy services. Today, actually, in Mombasa County, they launched the comprehensive cancer care. The CS, Mheshimiwa Mutai Kagwe, is actually opened that. We need more of those. Actually, we need more of those, and they should be amplified throughout the country. Yeah,
because that was my next question. Yes, we can have the talent, we can have, the medical personnel, but do we have the equipment to ensure that, number one, we diagnose, we can treat our own cancer patients in the country, which we all know the answer to. We're not yet where we're supposed to. But before we go back to that discussion, let's talk about a number of issues that WHO keeps on, mentioning. Breast cancer, along with cervical, prostate, liver, colorectal cancers, they account for almost half the new cases of the continent annually. Are we aware? Are residents or, citizens of different nations, not only in Kenya but in the motherland, aware of the risks that they can pose from, or the risk they have from cancer? Do they even know the symptoms that they're supposed to look out for, even before getting to, because Africans, how they work. I will not go get tested unless I feel like something is wrong.
Unless I have a problem.
Exactly.
Yes.
So are we there when it comes to creating awareness?
Okay, I think awareness is definitely lacking.
Yeah.
There is definitely a problem as far as awareness is concerned. And there is also that element, that cultural element of I'm not looking for something I do not know.
Yes.
Okay. What you do not know does not harm you. That kind of attitude.
Yes.
I think it's one of the first step. If you look at any cancer program, awareness is one of the first steps. And then comes in your screening.
Yes, the screening bit. Yes.
So awareness, we are still lacking. I know there are a lot of activities that are taking place. This is one of the activities that is actually taking place right now.
Yes.
And that is the whole purpose, is to create that awareness. There are talks that are happening. There are educational campaigns that are happening. The ministry already has its own programs that is taking place. Is it enough? We can do better. Yeah.
How do we do better?
I think the element of sensitization of the health fraternity as far as cancer awareness is concerned. We need to get out of the health is supposed to be treating malaria, treating pneumonia in children, and diarrheal diseases, and diabetes, and surgical intervention, and maternal and child health alone. I'm not saying those are not important.
Yeah.
They are very important. But if we are to address the issue of cancer appropriately, then we have to improve also on this particular aspect.
Okay. There's also an alarming projection. Allow me today, it's the statistics. We have to deal with the statistics first before we get to the other bit. Projections are that cancer deaths in Africa will rise exponentially over the next 20 years, outspringing the global average by 30%. We need to prepare ourselves for this, either way. How do we go about it?
Okay. So, first of all, I think we need to look at those particular numbers. It is important to note that our population will actually increase by more than 30%. So it's the numbers. The more the people, the more the chances of diagnosing this.
Yes.
At the same time, it's also the improvement of diagnosis. I can tell you, I underwent surgery 30 years ago, okay? And I had an appendectomy done. They removed an appendix. When I woke up, I saw the appendix next to my window, where I was recovering. Yeah. I actually went with the appendix home. Okay.
Is that scary?
So that appendix was not subjected to a histopathological evaluation.
Okay.
Okay.
Yes.
So whether something was wrong with that particular appendix or not, we don't know. Well, nothing was wrong with that appendix because I'm still here today. But what I'm trying to drive is even investigation of samples is not as much then as opposed to now. Right now the recommendation is whatever comes out of your body needs to be examined. Okay? Because sometimes you actually get incidental findings that a particular biopsy surgery has been done and a particular tissue has been removed and it's been subjected to a histopathological evaluation, and as an incidence a cancer is found.
Yeah.
That might not have been the clinical scenario. So and more clinicians are sending these particular specimens for evaluation. So naturally, the numbers will rise because the numbers then involve a certain number of tissues that were examined. Right now, the number of tissues being examined, say, are 5 times, 10 times, 20 times more. So naturally, your pickup rate will be high.
Okay.
So I think what we need to do is, again, stay at the basics, increase your awareness, improve your diagnostics, and that's not only pathology, it's also radiology, because in some countries, the US for example, radiology is very key in diagnosing very early non-palpable breast lesions. Yeah. So all the avenues of diagnostics, of detection, whether it's pathological, whether it's radiological, whether it is clinical, all those areas need to be improved. We need to invest in those.
All right. I wanted to take a short break, but we still have a lot more we're going to be talking about. Thank you very much, Dr. Sherman. He will be staying with me. After the break, we'll continue with this conversation on cancer. Keep it KTN News.